Hopefully by this point you've become aware that in Gallatin County we've instituted a change in our spinal precautions or how we immobilize patients and protect their spine. If you haven't, this will make you familiar with it. If you are aware of it but need more clarification, hopefully this will provide that. My email's at the end. Please feel free to send me any questions, either that you have about the protocol itself or questions that come up as you start to institute these changes. So, before we begin, a little bit of thanks to Brian Bledsoe out of Las Vegas area who helped with some of these slides. This same idea is happening across the nation. Many other areas and medical directors are instituting the same sort of changes, so there's been a lot of sharing of ideas, and many of these ideas that we've taken have come from other agencies who are instituting similar protocols. So, without further ado, what we are not talking about is a no backboarding protocol. Some places that have instituted this type of change, people have started referring to it as the quote-unquote no backboarding protocol. What we do want to put forward is more of a selective backboard use protocol. Every tool in medicine needs to be used according to its risks and benefits. What I'm going to try and do is give you some of the evidence behind backboard use so that you can use it selectively and hopefully towards a more targeted audience. Again, what this is not is in no way, shape, or form are we saying that you do not have to protect the spine. What we're saying is that there are times when it is appropriate to protect the spine without using a backboard, which hopefully improves the comfort and safety of our patients, as I will hope to show you. I don't think there's any debate that spinal injuries are bad. The average length of stay in the hospital after a spinal injury is 12 days, with 37 more days in rehab. If you look at some of the costs for a high quad, over $1 million of medical bills in just the first year, and that doesn't take into account losses to society, lost productivity in the future, emotional, and everything with family, etc., etc. So spinal injuries are bad, and they are something that we hope to avoid or to minimize the morbidity that comes from them when we encounter them. So why do we immobilize the spine? Well, our goal is to prevent what's termed secondary injury to nerves in the spinal cord. There's a primary injury that happens during the accident itself. The forces that are applied to the spine during, say, a car wreck, those cause primary injury. There's nothing that we can do about that part other than try to prevent accidents in the first place. Once that accident has already happened, our goal is to prevent any secondary damage to anything. If there's a partial nerve or spinal cord injury, we don't want that to become complete or to be worsened in any way. If there is a unstable spine but the nerves and spinal cord are intact, we don't want them to be damaged in any way. The idea is to then immobilize the spine, keep things from moving around to try to prevent any further damage. This is something that's not really this wasn't figured out based on any evidence. It was more extrapolated from fracture and dislocation care, the same thing that we use other places in the body. What do you do with a broken arm or a leg? You splint the joint above and below the broken bone. What do you do with a dislocation is you splint the bone above and below the dislocated joint. Same thing with the spine. The backboard attempts to splint the entire spine, all the joints above and below where the area of injury may be. Now, spine injuries can be divided up into stable and unstable. This is a slice through the spine looking from the side. Front is off to this side, back is off to this side. The spinal cord runs through the middle here, and there's a couple different types of injuries. If you were to get a break here or here, things would still be stable. The spinal cord would still be protected. These ligaments running down the back and the front of the spinal column would still be intact. These ones holding things together in the back would still be intact, and therefore the spinal cord in the middle would still be protected. However, if rather than those we were to break through here or here, that's what we would term an unstable injury. Now the whole support mechanism in the front or the back has been disrupted, or sometimes both, and therefore things can shift around and the spinal cord is no longer in that safe, protected cage. Unstable injuries are the ones that we worry about most. The problem is, without a CAT scan or an MRI or some other imaging, you can't determine stable versus unstable injuries in the field. Therefore, anytime there's concern for a spinal injury, we have to treat it as if it's unstable, as if things could be damaged more if we don't treat things right. So, we're not saying in any way, shape, or form do you not have to protect the spine. You still have to protect the spine just as much. What this new protocol is going to tell you is just that there are other safe ways to still protect against further damage from those unstable injuries. So, why do we use a backboard? Well, it makes a lot more sense to carry a patient out of the field like this rather than like this or like this. And a backboard is still very necessary for extrication. However, the time we're going to discuss the most is this. Once you get them to the stretcher, do you still need that hard, uncomfortable board, which sometimes can create damage, or are they safe on this stretcher here? So we use backboards all the time. Everyone's been practicing this skill since your first EMT class, but where's the proof that it makes a difference? Does it really make a difference? Well, anytime you look at anything in medicine, there's a scale here from things at the top that have proven benefit and no risks, and these it would be unethical to not use, right on down to, in the orange there, things that have proven benefits but proven risks. You have to weigh the benefits and the risks and figure out when you need to use that procedure. All the way down to the bottom, something with no proven benefit but proven risks. It would be unethical to use that procedure, medicine, whatever it was. I'm going to argue that backboards at best fall up here, at worst fall down here. So where's the proof? There's really only one study that ever tried to take a look at whether or not a backboard makes a difference in the patient's care. It makes a lot of sense to use a backboard, as we've just discussed. There's a lot of times, like carrying the patient out of the ditch or out of the woods, when it really makes sense to use a backboard. But where's the evidence? Where's the proof behind that? Now, it's been standard of care for so long that it would be really hard to do a study and just randomize people and say, well, the next 100 people get backboards, the next 100 don't, and we'll see who's going to do better. Because it's considered standard of care, so most people would consider it hard to pull that away from those patients. What these guys did is back in '98, they looked at two different systems. They looked at a system in University of New Mexico, which had our standard American pre-hospital system, bringing patients in immobilized when there was concern for spinal injury, and they compared that to a university in Malaysia. Still a good university hospital where the patients got good care in the hospital. However, there's no pre-hospital system to speak of there, so nobody was getting immobilized in the pre-hospital realm. Patients would just show up however they could get to the hospital, back of a pickup truck, limping in, brought in by friends. However, so really what they were trying to say is, hey, the care in the hospital is the difference, or is the same. The only difference is what was happening pre-hospital. They looked at spinal injured patients and checked their neurologic disability. The surprising finding was that there was less neurologic disability in the unimmobilized Malaysian patients at a ratio of 2 to 1. The same with patients with cervical injuries, but the rate was only 1.5 to 1. So this is counterintuitive. The ones who were not immobilized had less neurologic disability, and the ones who were getting what we consider a higher level of pre-hospital care with full immobilization had higher rates of neurologic disability. Well, there's a lot of problems with a study like this, going retrospective like this. There's a lot of problems with it, but this is all there is. There isn't any better data saying that backboards really make a positive difference. So, there's no proof it helps, but in a lot of ways it seems to make sense. So what's the harm in using it? Well, I'll argue that in some cases there is quite a bit of harm. penetrating trauma being one of the biggest ones. Here's a study looking at penetrating trauma patients and comparing their outcome, whether they got spinal mobilization or not. What they found was that penetrating trauma patients, gunshot wounds, stab wounds, 1,000 patients needed to be backboarded to help one patient. However, the number needed to harm, or the number you needed to put on a backboard in order to harm one patient and potentially contribute to a death, was 66. So every 66 patients you're contributing to harm, and you don't do benefit until you've put 1,000 patients on a board. Well, that shows that we're probably doing more harm than good with backboards for penetrating trauma. This makes sense, and there's multiple other studies that follow this same thread, and just showing one or two of each category to keep things simpler here. Penetrating trauma patients, gunshot wounds, stab wounds, are usually dying because there's a hole in something. That hole needs to be fixed. That hole needs to be fixed usually in the operating room, and it's the time until you get the patient to the operating room that makes a difference in their outcome more than anything. Putting a patient on a backboard and fully immobilizing them takes time, delays their entrance to the operating room and their time to definitive care. It also covers up some of the areas that we're trying to care for. It makes it harder to see their back, makes it harder to access some areas of the body. So it's also a distraction. There's more stuff going on. The providers are focused on other things rather than just moving the patient along rapidly. So this does make sense. And as I said, there's more studies backing this up. Here's another one. This looked at in Philadelphia. They have so many trauma centers and so much penetrating trauma that often the police will just put the patient in the back of the police car and transport them if they have penetrating trauma. And they found no difference in survival between police and EMS transports, and said that that should keep happening. Those patients are obviously not getting immobilized if they're traveling in a police car. Again, the time to get there is what makes a difference. Now, for blunt trauma patients, there's also problems with backboards. They increase pain and they also increase cost. Anyone who's ever been on a backboard, you tell me whether it's comfortable or not. I know the times I've been on them sure aren't that comfortable. So I think this won't be any surprise. This one looked at children presenting to an emergency department and found that given the same injury, patients who were immobilized had a higher pain score, and they were also significantly more likely to undergo cervical radiography or x-rays or CAT scans at a rate of 56% to 13%. So patients in a collar, patients on a board, we are much more likely down the road in the emergency department to x-ray them, to image them, than the same patient presenting without the backboard, without the immobilization. I think as important or more important here is the increased pain that we're putting our patients through. Here's another study looking at that. Healthy volunteers strapped to a board for 30 minutes. 100% of subjects developed pain within the immediate observation period. 55% of those subjects graded their symptoms as moderate to severe. We're supposed to be helping these patients, not make them more uncomfortable and in more pain. So if there's a safe way to transport them without them on this uncomfortable board, that would be great. How about airway and breathing? Our primary concern in any blunt trauma patients are our ABCs. So let's start with A, airway. Anybody ever seen this patient come in? Well, usually it's not that bad, but cervical collars and spinal immobilization do reduce mouth opening, and they do interfere with airway management. And again, there's multiple studies backing that up. Aspiration. It's pretty hard to roll. This patient cannot protect their own airway if they vomit. They need somebody right by their side to roll them immediately. That increases the risk for aspiration. Backboards and full immobilization also restrict breathing as well. And again, there's multiple studies looking at this. Here's one, and they found differences. These differences reflect a marked pulmonary restrictive effect. So it restricts the ability to breathe, restricts the ability, the lung volume that the patient can breathe through. Here's another one looking at healthy children put on a spine board, checking their forced vital capacity, or how much they could breathe out. when they were standing, and then when they were down on a board. They found that their volumes were 40% to 96% when they were down strapped to a board. The average was about 80%, and that's the usual in most of these studies. The kind of the general is that full backboard immobilization restricts your respiratory capacity 15 to 20%, which is significant. Often these patients are limited in already in many ways, and then if we restrict their breathing by another 15 or 20%, that can be very significant. Here's another one. Healthy volunteers, both the KED and the long spine board cause a decrease in pulmonary function. So airway, compromised. Breathing, compromised. Pain, definitely. There are definitely problems with the backboard. So we have no proof of benefit. We've shown the potential for significant harm. The question comes, this has been standard of care for a long time. Are we safe to try something else? Spinal injuries are a litigious area for injuries, and we need to make sure that we are safely protecting patients before we change what we're doing. Well, there's quite a bit of studies showing that patients can probably actually do better on their own. This study used video motion capture, so putting sensors on patients, videoing them, and using computers to check how much motion their spine is undergoing. They put them in a mock extrication, and they were either extricated in the usual way or put a collar on them, and then they were assisted in extricating themselves. And what these guys found is there was a significant decrease in movement for all motions when the driver exited the vehicle unassisted with a cervical collar, compared to when they were unassisted and without protection, or compared to when they were being fully extricated by providers. Here's another one, again, bioanalysis. Conventional extrication techniques record up to 4 times more cervical spine movement during extrication than controlled self-extrication. This makes sense. It's pretty hard to hold somebody else's head, neck, and spine perfectly in line while they're traveling through a range of motions, including twisting and up, down, back, forth. However, if you're told to hold your neck, head, and spine rigid, you can do that very well. You can guard your own spine, neck, and head much easier than somebody else can for you. So a patient who is alert, awake, can follow directions, and is told to keep their spine in line and coached on that will probably do a much better job than you or I will do trying to hold it for them. These studies are lab studies. These are not ready for transition to the field, and we're not changing extrication techniques in any way at this point. But they prove a point in that patients do a good job of guarding their own spines. So finally, at the beginning of this year, we got some backup from a couple national organizations. This is a position statement that came from the American College of Surgeons Committee on Trauma and the National Association of EMS Physicians, 2 big players in pre-hospital care and in trauma care. And this position statement, I think, is what finally gave everyone a big sigh of relief and the ability to say, hey, going forward, we are now safe to try something else. We're backed up by some of the big names out there. Here are some quotes directly from the position statement. Long backboards are commonly used to attempt to provide rigid spinal immobilization. However, the benefit of long backboards is largely unproven. Great, that's what we just covered. There's no proof that they really make a difference. The long backboard can induce pain, agitation, respiratory compromise. It also can lead to the development of pressure ulcers, another complication I didn't even cover here. Utilization of backboards for spinal immobilization during transport should be judicious so that the potential benefits outweigh the risks. Great. Here we are up here. There's probably some proven benefits in terms of extrication. There's also definitely some proven risks. So we have to use the backboard selectively, applying a risk-benefit analysis to decide if it's right for our patient. How about penetrating trauma? Patients with penetrating trauma to the head, neck, or torso and no evidence of spinal injury, i.e. they don't have paralysis already, should not be immobilized on a board. All right, here we are back down here. It's not right to put these penetrating trauma patients, if there's no sign of paralysis or obvious neurologic injury, on a board. we can make them worse. This is the one I think is the best and the most helpful. Spinal precautions can be maintained by application of a rigid cervical collar and securing the patient firmly to the EMS stretcher. So now there's a certain class of patients that don't need a full board and all the duct tape and straps that go with it. We can put them in a seat collar, we can lie them on the stretcher, we can use the seat belts and coach them how to keep their spine protected. These are patients who are found to be ambulatory at the scene, that low-speed motor vehicle crash patient who's walking around and says, yeah, my neck hurts a little bit. Patients who have to be transported for a protracted time. In our area, maybe the patient coming down from Big Sky who has an hour-plus transport in the back of an ambulance, or patients for whom a backboard is not otherwise indicated. So key in this is what we talked about again at the beginning. Whether or not you use a backboard, attention to spinal precautions among at-risk patients is paramount. Again, we're not saying don't protect the spine, we're just saying protect the spine in another way, that there is a safe other way to protect the spine for some patients. There's plenty of studies out there showing that a collar is not perfect, and you still need the right patient who you can coach to maintain that inline stabilization themselves. So how do we implement this? Well, the backboard's a tool. Still need it for extrication. You can't carry the patient out of the ditch and out of the backcountry on a soft, squishy mattress. You need something rigid to be able to transport them. How about the confused or altered patient? The patient who's repetitively asking questions, won't follow commands, won't lie still. You need it for them. We also still need it for our trauma team patients, the multi-trauma, severely injured patients. The backboard is very helpful when they arrive at the ER. We can quickly slide x-ray cassettes underneath there, shoot x-rays right through it. They're often getting moved from the stretcher into the CAT scan, back to the stretcher, to the operating room, and it provides an easy way to transport those patients back and forth too. So for now, our multi-trauma, trauma team activation patients still need a backboard as well. So how are we going to implement this? If you read through the Gallatin County protocols, there's essentially 3 levels. Levels 1 and 3 are no change from what we had before. We're just adding a second way to protect the spine for the lower risk patients that you still have concern about their spine. Level 1, same as what we used to have, full spinal immobilization. And again, going back to the position statement, appropriate patients to be immobilized with a backboard may include those with blunt trauma, an altered level of consciousness, neurologic complaints. If they already have signs of an obvious neurologic deficit and spine injury, better to just keep them immobilized on the board. Anatomic deformity of the spine, or those who've had severe injuries. That, again, is no different than what we've done before. You still put them on the board the same way that you used to, still immobilize them the same way. We still have the ability to clear the spine. We always have. You don't have to bring every knee fall with a twist and a knee injury in immobilized on a backboard. We've always, for years, we've had criteria in there for when you don't need to provide spinal immobilization. That is unchanged as well. What we're adding is a new level that we've been terming loosely spinal precautions. This is for the patient where you're not able to clear them, you're still concerned about their spine, but they fit a set of criteria that allow you to transport them not on a backboard. The patient must be fully alert and cooperative. Again, this is not appropriate for our multi-trauma patients, and the backboard is still appropriate for extricating the patient until you get them to the stretcher. So 2 cases I think are the ones that best illustrate how to use this. The ambulatory motor vehicle patient walking around at the scene of the accident, low speed rear ending. They come up to you, they say, yeah, my neck's a little stiff and sore here. You push on their neck and they say, ow, that hurts. In the past, that meant a standing takedown onto a board with everything that went with that. If they're accessible to the stretcher now, that means have them put a seat collar on them while they're standing up, have them sit down on the edge of the stretcher, coach them in keeping their spine and neck in line, and have them pivot and lie back onto the stretcher all in one motion. You can assist them by helping lift their legs up, and then strap them down onto the stretcher for transport. I think, as you can imagine, that sitting down and just pivoting straight back onto the stretcher is probably a whole lot less motion to the spine than us trying to do a standing takedown and take care of that patient ourselves. They can probably protect their spine a lot better in that instance than we can. The other one being the patient who's extricated with the backboard and then has a long enough transport to the hospital that it makes it worth log rolling them up, sliding the backboard out, and log rolling them back down onto the stretcher. You're still protecting their spine. You're still doing the same log roll maneuver you used to put them on the board to take them off it, but they can then transfer to the hospital in a much more comfortable and probably a situation with less complications than if they're still strapped to that hard board. A couple examples: you come on this accident, 50-year-old belted driver, no loss of consciousness, fully alert, ambulatory but limping, has a little bit of moderate neck and T-spine tenderness on exam. That is a patient who would be appropriate for spinal precautions. You could put the collar on, sit them down on your stretcher, buckle them down, and transport them that way. Another one, the 30-year-old skier at Bridger Bowl, brought down by the sled and spinal immobilization, fully neurologically intact on evaluation in the patrol hut, but has some head, neck, and back pain on exam. That's a patient that would be appropriate to roll off the board on the transfer over to the EMS stretcher, and they could ride the ambulance ride into town secured to the stretcher with seat belts rather than, again, strapped to that hard board. Contrast that to this wreck. You got a 24-year-old, positive loss of consciousness. He's got crushing chest pain. He's vomiting. His left femur's pointing off in the wrong direction. He's got no neck pain, and he seems alert and oriented to you, but this guy's got too much distracting stuff going on. The chest pain, the vomiting, the femur. He's going to be a trauma team patient, and he's going to need that backboard for full protection. So, in summary, the backboard's a tool that needs to be used selectively. Not using a backboard does not equal not protecting the spine. Even if they're not on a backboard, pay attention to the spine, even if you're removing that visual cue that we've always used to say this is a spine patient that we're concerned about the spine. Get a hold of the Gallatin County protocol for this. It's listed on the Gallatin EMS website. Email me if you need a copy. My email's down here at the below. And remember, you can stabilize the spine without a backboard. There are ways to do it. And hopefully as we move forward, we can keep our patients more comfortable and just as safe and just as protected. Thank you.